Let's move on, and we have the fourth and the last panel discussion, and I'd like to introduce our moderator for the session, Professor Vivian Lee, who is also a longtime friend and colleague of mine. And she's the Associate Professor of the Center for Learning, Enhancement and Research of the university. She is a clinician scientist of clinical pharmacy outcomes research to chronic disease management, utilizing the skills of clinical pharmacy, pharmacoeconomics, and interprofessional education to improve patient care. She is also the president for the International Society of Pharmacoeconomics and Outcome Research, the Hong Kong chapter. Professor Lee, please.
Thank you, Dr. Fong. It is actually my great honor to be here. And we have some discussion yesterday related to the sustainability of healthcare. And then I think Dr. Honorable David Lam mentioned three factors, the talents, facilities, and also financing. So today we're talking about financing. And this topic is actually attract thunder and lightning this morning. And I'm very delighted that we have very renowned speakers today. Professor Peter Yuen. Professor Yuen is both scientist and also economist. And Professor Yuen actually received undergraduate degree in cellular and molecular biologists, and also further enhanced his study in the Master of Business Administration and his PhD in health economics. So his research area is mainly to focus on policy evaluation as well as the health service management. So he will actually deliver his presentation on the topic today for the financing to support the sustainability of healthcare. And then followed by Professor Yuen, we'll have a respondent, Professor Albert Lee. We don't have to actually introduce much. He is our renowned speaker and also our Emeritus Professor at the Jockey Club of our School of Public Health and Primary Healthcare in the Chinese University of Hong Kong. He's an expert in primary health and also primary health care. And followed by our Professor Lee, he will actually have two discussants. Okay, we originally have three, but then now we have only two because I was just informed that Dr. Ng is actually not well. We'll wish him well and hopefully he will recover soon. But without Dr. Ng, we still have Dr. Lee. Dr. Donald Lee is the chairman of the Elderly Commission. He is also the past president of the Hong Kong Academy of Medicine. He is also a very distinguished medical practitioner both in Hong Kong and China. And he is actually further support the training and the development on primary health care in both China and Hong Kong. And our last but not least is actually Dr. Jonathan Wei. Dr. Wei is actually the medical superintendent of the Precious Blood Hospital, Caritas, and he also actually have honorary appointment in both Hong Kong U and also Chinese University. After all the presenter presented, we will actually open the floors for discussion. So without further ado, I would like to turn the floor to Professor Yuen. The floor is yours. Thank you.
Thank you, Professor Lee, for the kind introduction. I'm in addition, Vivian described me as scientist and economist. I'm now more like a businessman. I manage a self-financing college in PolyU, and this is actually my full-time job. So healthy economics is a hobby of mine now. I spend all my time trying to balance books in my college, and that's very challenging. So I'm very delighted and honored to share some of my views on healthcare financing. So I thank Anthony and Ben for inviting me. So this is something I've been working on for the past 20 or more years. I have a passion for money side of things in healthcare. So today I'm going to maybe share with you some of my findings on analysis of whether Hong Kong's healthcare financing system would be sustainable. We all heard about, problems, but is it really going to be non-sustainable? How bad will it be, or is it still going to be okay? So this is the Hong Kong system. We have a two-pillar system. One is the public pillar, which is the blue side, and the private pillar. And roughly, in terms of money, I think it's sort of 50-50, with the public side, of course, more predominantly on hospital, on secondary and tertiary care, and the private side, or mostly on outpatient primary care, with also a small sector of private hospitals. So it's roughly the same in terms of financing. So 80 billion to Hospital Authority and some to Department of Health. And the private sector spending is about also 70+ billion. Of course, majority are outpatient visits. And the public sector is heavily subsidized, up to something like 97% of the costs. The private side is zero subsidy, so it's kind of a 0 and 1 kind of thing, although there are some now share care, voucher and all that, but it is still sort of in the margins. And so that's the situation. This, I think, Dr. Lam yesterday showed the different sources of financing in Hong Kong, and tax is about 50%. So most of our public hospitals are funded by taxation. And the second largest component is out-of-pocket, and that constitutes about 35%. And then the rest would be insurance. So insurance is about 15%. And there are actually three bars, but one bar is almost disappearing. The light blue one would be group schemes, and the yellow one would be group schemes, meaning employer-sponsored, and then the blue one, the light blue one, would be individual purchase plans. So that is again half and half. And then so of that 15%, maybe about 7%, would be group, 7% would be individual purchase plans. So when we talk about insurance, it is not a major player in Hong Kong. So insurance, it's constitute less than 15% of the financing, of the total financing budget. So it's tax and out-of-pocket. So if we have problems with tax income, then we will be in trouble. The system is already strained. I guess people in Hong Kong know. So this is the waiting time for a total joint replacement, so taken from the Hospital Authority website. Some clusters are really, it's 95. It's not 95 days. It's not 95 weeks. It's 95 months. So we are talking about years people are waiting. This is, of course, the 19th percentile, but some patients are waiting that long. And even for median time, the first row, median time is, it's not short either. So for New Territory West, people have to wait 56 months. And so meaning 50%, median time, meaning 50% of the patients were actually waiting more than that, and then 50% less than that. So that is not a very good situation in Hong Kong for non-urgent conditions in public hospitals. But of course, if you have money, you can get it done in the private sector quickly. So is the system financially sustainable? We heard a lot about it. There's been many government consultations, studies, and the Harvard report that was actually well discussed, it was 1999, so a long time ago, predicted that the system would not be sustainable, okay? The quote, from Professor Xiao saying that, this is highly questionable. But how bad is it? Is it really not sustainable? So I think the major challenges, apart from many other things, I think these are the two major challenges. One is population aging, which we are all acutely aware of, and the second one would be medical inflation. So I would look into these two factors. Now, aging population is really worrying in Hong Kong. And not only do we have more old people, but we have fewer and fewer working age people. So these are the people who pay taxes. And if we have a shrinking tax-paying population, how are we going to finance our public hospitals? So since 2018, we have a declining labor force. And the decline is a sustained one, not a short-term one. So if you see, we're on the constant decline. And this projection did not account for the emigration that happened last year. So the situation is actually much worse than this. Those who emigrated are all young working age group. So that's the first thing we need to bear in mind, not just having more elderly people, but we have a shrinking tax base because of that. Then the retirees is also a concern. So 2013, 10 years ago, if you look at the pyramid, the bulge is still within the working age group. So it's still okay. Now we find the bulge moving up towards the retirement groups. So I think that is the situation. And then if we look at 10 years from now, then we find, the top is almost a little bit larger than the lower half. So meaning there would be more people not working, not contributing to taxes, but the people who are contributing to tax revenue of government would be less and less. So is it going to be sustainable? Now, the second factor is medical inflation. So how bad is this? We all know medical inflation is a worldwide phenomenon. And I've used some local data. I track the private health insurance claim data as well as the premium data over years. And it's actually quite a good regression line. The fit is very good. And roughly it is about 4.5% per year. And in the past, like from 2017 onwards, so we saw it's about 4.5%. And in those years, the general inflation was actually very low. So we're talking about medical inflation is about double that of general inflation. So general inflation is about 2%, but medical inflation is about 4.5%. So that's mainly due to new technology, new drugs and new way of treating patients, plus some providers' behavior. So how bad will it be in 20 years from now? So I look at some parameters. So number of people we have, number of elderly people, medical inflation, and economic growth. I think that is very important. So we have been doing okay. Well, not fine with all this waiting list, but still okay because we have economic growth. So government's revenue year after year was still increasing. So the government was able to give more and more money to HA. So this is my forecasting model. So population is one factor, but more importantly, elderly population, and then medical inflation. So that constitutes the kind of the demand side. And on the supply side would be if we have economic growth, then government will have more money, and government can spend more money on public health care, right? So that is my forecasting model. Population is by 2039 would be about 8.2 million, and elderly population would be 32% then. So super aging society. Medical inflation, assume it would be 4.5% every year. And then economic growth, I use two assumptions. One assumption is we maintain the same rate as in the past 20 years, so which is 2.7%. Or because of aging, because of the geopolitical situation which affects our economy, so it's only half of that, so 1.35. And then all along, government's finances is about 20% of GDP, and government has been allocating about 18% of its total budget to healthcare. So these are the parameters and assumptions. And so let's look at the situation in terms of funding. So currently we have, I use 2019 data because that is pre-COVID. So it's not affected by COVID. So everything is pre-COVID. So 2019 funding was about 72 billion and to hospital authority only, so not counting primary health care. So population was 7.5 million, and elderly person constituted about 18.5%, okay, 18.5%. So I use a weighting of 4. So every elderly person would consume maybe 4 times that of a non-elderly person in terms of healthcare expenditure. That is sort of the international average. In Hong Kong, the hospital authority numbers are 6 because they only look at inpatient. So I use 4, which is more moderate. So the rest would be non-elderly population. So after this weighting, so I would say, so by 2039, so the population would be equivalent to 11.7 million non-elderly population. I use the population units, which are non-elderly. So if I use the existing level of funding, so each person per population funding would be $6,000, okay? So that is the funding level. Now, if we go to the demographics in 2039, then if we want to maintain the same level of funding, we would require 100 billion, okay, just because of the population. So population alone would require 100 billion just to maintain current level, no improvements, okay? And if we look at medical inflation for the next 20 years, again using 4.5%, what would happen? Then funding level would become 241 billion. So not 100 billion, so if you count medical inflation. Then we look at GDP growth, economic growth. So scenario 1 would be we would be able to maintain 2.7% per year. And our GDP by then would be 5,000 billion or 5 trillion. Public expenditure, 20% of that. Public health expenditure, 80% of the public budget. So the requirements would be 241 billion. So we would be short. How much? 30% short, 30%. So a very significant percentage. So if you imagine the hospital authority, I would cut his budget by 30%. How would it operate? So we already have waiting time, in 90 months. So if I cut the budget by 30%, I don't know how long the waiting time will be. And that is also a very optimistic projections that we are able to maintain the same amount of economic growth. If I cut the economic growth by half, then we only have, we're 70% short. So I think the whole system would collapse. It would not work if I only give 30% of what the hospital authority needs. So it is really not sustainable. So will more private health insurance help? So this is what government is trying to do, right? Pushing voluntary health insurance. But as we see earlier, private insurance is only like 15% of the total picture. And what government is pushing is only individual plans, and that is only 7%. And plus, there are a lot of problems with the VHIS scheme. They are not that attractive to elderly, because it is what we call experience-rated premium. The premium are charged according to the insurance company's experience, and if you are old, you pay a lot more. If you have pre-existing conditions, you pay a lot more and all that. So it's not attractive to elderly. There are some tax incentives, but if you're retired, tax incentives are meaningless. So premium is very high and they have no income. So when you're young, the premium is very low, $2,000 a year or fine, and then you get some tax remission. But when you are elderly, retired, maybe $30,000 a year, no tax incentives. And even the government's consultants projected that the public-private mix, even with the VHIS, the changes would be very marginal, about 1% difference. So what about all these primary care initiatives that we heard yesterday? Will that help? We hope so. So we have the district health center, we have the primary health care blueprint. But where are we going to get new money for primary care? So this is my question. So if we want primary health care to work, we need to finance it, right? So where is the money coming from? Is it realistic? Can we find new money from it? So this is the government's financial situation, right? We have been in the red for since 2018. And in the past, there's been government surplus. But even 2023, it's still a deficit budget. So is it realistic for government to find new money to fund primary care? So I don't think so. So what needs to be done? So I think we need to drastically improve efficiency. So economists looks at there are two types of efficiencies. One is called allocative efficiencies, and the other type would be technical or X efficiency. So allocated meaning you put money where it would derive the most benefit. And X efficiency is after you get the money, are you really spending the way in the most efficient manner? So in Hong Kong, I think, performs badly on both counts. In terms of allocative efficiency, we put all the money in public hospitals, in secondary tertiary care, not in primary care, not in community-based care. So that is the situation. And not only that, 50% of all hospital admissions were found to be inappropriate. They can be treated on an outpatient basis. So 50%. So I can cut HA's budget by 50% and use that money to fund primary care. So there would be ample money to do primary care. But is government willing to do that? And same thing for long-term care. 65% of all those who are applying to stay in residential care facilities do not need residential care in terms of the physical health. And our spending on primary care is, of course, not enough. So it's only 17%. And that is already highly inflated, I think, because that includes all the regulatory functions of Department of Health and all that. So as I've indicated, that we really need to just shift our resources to more outpatient ambulatory care. And ambulatory care saves a lot of money. You don't need 3 shifts of staff. We talk about staff shortages if it is done outpatient in 1 shift, but now in inpatient 3 shifts. And it's more convenient and all that. And same thing for long-term care. So I think to remove the allocative efficiency, you need to put everything in one roof, put everything controlled by one authority so that that authority can shift resources. Because right now, hospital authority is not willing to give up any of its resources. They look at my waiting time, you go, look at my hospitals. We have 5,000 new hospital beds that I need to staff and all that. So you need to put them under one roof so that that body can shift resources. So by one roof, I mean both governance, budget, and staffing, all controlled by one authority. So it's not that you work for hospital authority, you work for the Department of Health, you work for one body, and then you can, the authority can redeploy you to work in nursing homes and work in primary care facilities. So you can shift resources around. So my thinking is that one health authority, put hospitals, outpatient, district health, long-term care under one authority, centralize all the money, everything would be under that authority. They can shift things around, resources around. And the second thing is the efficiency or technical efficiency. So most people think hospital authority is already very efficient, right? Oh, we need to look after so many patients and all that. But actually, I did some calculations. Is it really more efficient than the private sector? So what I did is I would use the VHIS basic plan for the entire population of Hong Kong. If I buy private health insurance for the entire Hong Kong population, how much would I need? Would I need more money than what we give the hospital authority? So here, if I bought it for the entire population in 2021, I would only need $47 billion. $47 billion. We gave the hospital authority $80 billion. So I would save half the money, okay? And everyone, I can send them to Baptist Hospital, send them to Precious Blood Hospital, Sanatorium Hospital. They don't have to wait. And then the hospital authority would probably say, no, we do a lot of non-inpatient services. So I factor that out. So inpatient service would be 54%. So they are doing a lot of inpatient services, like specialist outpatient clinics and visiting nurses and all that. So even that, I think it's 50 billion. So that would still be enough money to buy health insurance for everyone. So this just shows that our public hospitals are not that efficient. And the reason is very simple. The funding model is a block grant model. So hospitals get money whether or not they work, they do. It's not outcome, not even activity-based. So now in most countries, they're moving from activity-based funding to value-based funding. But we are not even activity-based. We are historical-based. So just one block grant based on what you get last year, you would get more or less the same this next year. And then patients go there. So if you work hard, then you are doing a disservice to your hospital. You are just attract more patients. So everyone try to be less efficient so that they don't get more patients. So they go to the other clusters. And so there are this what I call serious perverse incentives. So money goes to hospital whether or not you do a good job. And you actually penalize good service because you will attract more patients, and you would reward bad service because patients will not come to your hospital. You still get the same budget. No incentive to be efficient, and longer the waiting time, the more ammunition you have to get more resources from the bureau. So we really need to do away with block grants to hospital authority. Money needs to follow patients. So no country in this world still get block grants like Hong Kong do. So UK did away with that 30 years ago. Okay, New Zealand is not like that. Australia is not like that. So we are the only ex-Commonwealth country that still do block grants. So we need to change to a money follow patients model. So just you spend the same amount of money, give it to a fund holder. That fund holder would fund hospitals based on the volume of work they do. They would also allocate some money to primary care, to long-term care. And you can send patients to Baptist, sanatoriums, to St. Teresa's if you want. So my conclusion is the health financing situation is really gloomy based on aging population, fewer taxpayers, low economic growth, narrow tax rate, narrow tax base, and we do not have any really significant supplementary financing mechanisms. So even if economic growth can be maintained, I think our quality of care would still be much worse off. But if economic growth is reduced by half, the system will not function. So status quo is not an option. Doing things more or less the same, I think, would be grossly irresponsible. So I think drastic change is needed to improve both allocative efficiency and exit efficiency. So that's all I have. Thank you.
Thank you, Professor Yuen, for wonderful and brilliant, actually, presentation and your thoughts and views on financing sustainable healthcare system. So now I would like to actually introduce, invite Professor Albert Lee to respond.
Okay.
Thank you.
Okay, thank you, Vivian, for the kind introduction, and thanks, Peter, for the excellent presentation. I also got very interested listening Peter's presentation, but my heart health will decline by seeing all the horror we're going to face, right? All right. And I've been listening, and they've been building on the data, and more and more interesting, more and more urgent thing. But my heart rate will go up, and my coronary artery may not last that long, all right? But we need to do something about it. I think Peter alert us the medical inflation keep going up faster than general inflation. That's one point, and also definitely our face with our economic growth. And basically, I'm paying less. In a way, I'm so relieved I'm paying less tax now after retired full-time position. And you have a lot we've heard about. We have several 100,000 people moving out of Hong Kong. They are the main taxpayer, the big taxpayer in future. And well, if we're going to sell, another income is rely on land sale. But what's the consequence? The property price will go up. So we are facing in terms of economic challenge ahead. We don't have to rub it in. It's going to be a tough time in the next 5 or 10 years for Hong Kong. So now, that's already something that we need to find a way to improve efficiency, as Peter has already mentioned. We won't find any more money unless we find oil field suddenly somewhere in Vietnam Island. Okay. Now, aging population issue, but sometimes I always, in the public talk, whenever we have elderly birthday, we wish them to live for 100 years. So now we're always saying that it sounds like the old people be creating problem. But I think it's the issue is get them to live healthily, less rely on expensive healthcare. That's what we should be doing. And now, the Honorable Dr. Lam, David, dissect out the manpower workload, but the things have not changed since the day I was young. All right, maybe the emergency, we talk about the overcrowding. I think Donald and I worked at the emergency department the day when we were young. Things haven't really changed, right? So, and Michael talked about equity and quality, and he raised as no SDG on health security, secure healthcare system. And I think Illinois highlight some of the things they've done in Australia. Look at other sustainable development goal, ecosystem, health and justice, all right? And climate change, which has been flagged up during the public health crisis. And we are not having any concrete specific policy towards other SDG related to healthy living. We also flagged up in a session about education. Do we teach our kids healthy living? All right, so I think other SDG goal we still have to worry about. Okay, now I was just doing a quick calculation. I hope my calculator was right when Peter discussed the X efficiency and efficient resource allocation. All right, and I think this cannot be resolved unless, and we are now doing a lot of things in silo. As Peter quite right, unless we integrate, have a big structure change. And now we have done the dissection. We find out, and my talk yesterday is all in silo. We need to put under one roof, one single funder. We need to do radical surgery. So we can rely on Dr. Lam to drive this as a surgeon anyway, okay? So I think without the lack of structural integration, interfacing, only way to force people to work is put under, I've totally always learn a lot from Peter, is one funder, all right, whether you like it or not, all right? Now, I do have a little calculation, rough estimate, inpatient bed, low estimate, 5,000 per night, most expensive, or even more. Most expensive bed in Hong Kong is the bed of Prince of Wales and Queen Mary Hospital, not Four Seasons. Okay, 5, all right? And emergency, another 1,000 per admission, emergency. Now, let's say, if me being a JP, I could save every day 1 day of admission, which I think is possible if providing other infrastructure. Could I save one of my patients not going to A&E, if I provide better care, I could provide better care. I could. So I help the government to save $6,000. In 365 days, that's become 2.2 million. And we have around, just take a 5,000 GP in Hong Kong, I think we can contribute 11 billion. I hope my calculation is right. All right, so little thing we do, if we streamline to what we do in day-to-day general practice, we could contribute, I think, 10 billion or collectively. All right, but then we need the infrastructure to help us to do it. But we can do more. We can, if we're doing, we can save 2 or 3 admissions per day. Then we will recover that 57 billion. All right. So now when it's increasing call for personalized healthcare, I know that respect deal with our biomedical scientists and advanced in medicine looking into new drugs and genetic and target therapy, and this is great. All right, I got to say great because my son also in that molecular science as well. But I think epigenetic, talking about genetic expression, also have an impact environment. Sometimes we look at one side, we got to understand why certain people, similar background, they end up the different health outcome. It's the impact environment, the physical and social. So unless we also invest in that, then why certain people live longer. And I think there's some discussion the longevity of life, and those actually living 90s is our generation, like my parents and uncle and auntie, they gone through adverse environment to a better environment post-war. So that make a lot of difference. And in fact, a lot of things like housing policy in the past and a lot of building social infrastructure in the 60s compared to what happened pre-war period, that makes a lot of difference, okay? Well, I think we need to think outside the box in terms of healthcare planning and look into, I think both Michael and Sally also, were Sally highlight, and Eleanor look into some of the junior level of healthcare worker, right? About non-dispensing pharmacy, physician assistants, and day-to-day care, right? They could play a great role. And the strategy, I think Sally did discuss a lot about, enlighten us about the strategy. And then voluntary health insurance, I actually opened it in one of my family letter Hong Kong, and it's even it's broadcast out there. I'm too old, I know it's basically a joke, right? I think, and Peter also already rubbed it in, all right? And I think hopefully there should be a paradigm shift for insurance coverage. And I'm a declared angel. I might also do some medical legal consultants for insurance firm. I always advise them, provide incentive for better health, total health, rather than just focus on disease, okay? And the risk management should look at the infrastructure, okay? So I think nowadays action is very much needed than just policy paper, and we could look in the whole patient journey, all right? And from when they're born into the call back to the God, and along the pathway, how we could make a cost saving by improving efficient healthcare. And I think that's something that we could hopefully will save up the billions of dollars. That's my some sharing for the enlightenment from the other colleagues.
Thank you, Professor Lee. Now, after Professor Lee responds, I would like to actually invite Dr. Lee to actually provide his views on this very urgent topic.
Thank you for the opportunity to join this discussion. Indeed, healthcare financing is most important, for sustainability of healthcare systems. Totally agree with the points Peter made. Just want to go into a few points that he mentioned. First of all, of course, primary care. I'm sure family medicine, a lot of discussion about the benefits of this, from gatekeeping into the health system, efficiency using, but again, agree the money follows the patient, okay? If right now the allocation is like probably 10% of the health budget, maybe even not, or under health hospital authority, it's not going to work, basically, if the money doesn't follow the patient. And then secondly would be incentives, for quality at the primary care level, rewards. Okay, recently the introduction of the co-care. There are some principles of, I'm sure this is covered yesterday, but in general, I think reward as a practicing family doctor, first of all, I want more support, not money support, but the primary care team so that I can access, and I think the district health centers are a very good start in that sense, that so that doctors no longer need to hire their own staff, but have a whole team to back them up to provide holistic care. But to follow slightly on funding of primary care, I want to talk briefly about insurance. I think, despite it's a small percent, there's something that can be expanded. I think in the future. Actually, the voluntary health insurance scheme is just a watered down version of what was originally proposed, a much bigger scale. And I remember the days, Peter and I was at the Bohemia Foundation, our study, we recommended, first of all, almost mandatory insurance, because that's the only way you can sustain medical insurance. You start young, it's like a savings plan, and then there's a lot of risk sharing, and then when you need it, when you need to use it at an elderly age and all that, you're basically using up what you saved in a way. But everybody needs to join, because right now, the reason why Peter also pointed out that it's not attractive to the elderly, it's because it's very expensive. And this is all calculated, mainly the insurance company knows that you're going to use it basically after a year or two, and you're going to use up all that you paid. So there's no risk sharing whatsoever. So I think the whole thing needs to be expanded, and there are a lot of problems with existing medical insurance. The voluntary health medical insurance is a much better way forward, but it's still very selective. In the services provided, the range is not sufficient, and in fact, it's discriminatory because a lot of there's still exclusions that people who buy the insurance, and when the insurance company knows that they're going to use certain chronic illnesses as such, they will exclude, and all these little things. So I think the whole thing needs to be regulated. But together with this is also a medical savings plan. I think Honorable David Lam is quite keen. He tried to launch this at LegCo, but the labor forces was against. But still, this is still something I think we need. And this is back to patients' responsibility of their own health. Okay, we are concerned that we want people and patient engagement. We want them to be responsible for their own health. That's why I engage into preventive health with family doctors, keeping themselves up. But also there is a financial obligation, because if the government's going to go broke sooner or later with this kind of model, you need to contribute, basically. And again, there were proposals that we worked on, medical saving plans that can be really saved. And if you don't use it, it can be transformed to the next generation. So that's a very good incentive. But again, all these need to be mandatory. And so our politicians need to assess, the popularity of doing something like that, whether it's going to go through. But I think there's something that definitely needs to be truly considered. Lastly, I think efficiency, basically. We noted primary care, family medicine, and all that is in the healthcare system. Albert cited, if you keep the patient out of the hospital, out of emergency, you can say blah, 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 and all that. But not only that, overall efficiency in the primary care level, and that's where technology comes in, telemedicine, all this emerging thing. I think we need to invest into all this so that the efficiency in the community level would be much enhanced and really provide. We don't like to use the word gatekeeping because actually it's an admission into the health system, but still unnecessary admissions, unnecessary stay in hospital, all this, I think, technology. So again, when we train our future doctors, family doctors, I think this element is very important, that we're up to date with technology and all that. So I think I'll stop at this point and engage in more discussion later.
Great, thank you, Dr. Lee. So last but not least, Dr. Wei, your thoughts, please.
Thank you very much, Anthony, for giving me an opportunity to this discussion. Thank you, Professor Yuen. I've been hearing the talk for this is maybe the fourth time. The first time is about 6 years ago in one of our society symposium. And today is really an update for us. Well, as you know, I'm working in the private sector and have been engaged for so many years. And now I'm working as an administrative office in my hospital. So before going to go deeper, as money is very important, I want to give a very simplified picture of how the private sector, especially in the private hospital, working. So now, in the private sector, we have primary care, we have hospital care, inpatient care. So we have outpatient department, including general outpatient and also specialist outpatient department. So we generate the revenue from these by patient coming to the hospital, more or less like a clinic, okay, as in the GP clinics, but this clinic just in hospital, that's all. And then this is one of the revenue or income. And then the main bulk of income is also admission, patient admitted to hospital for management. So all this general revenue, we're going to what? To subsidize the normal routine functioning of a hospital, I mean a private hospital, not being subsidized by anybody, but by the patient, by the clients, okay? Well, we need to spend the money on whatever, staff salaries, the daily update, hardware, equipment improvement, equipment maintenance, all this all year round working. So we need a very tight or really careful budgeting in terms of money. And it's really difficult, I would say, but it's important in order to maintain our staff can have the salary, payroll every month. Okay. Now, I know time is tight. And now I'm going to just assess my view on how well is the budgeting is doing. So far, I have not been seeing talk about the budget on how the primary care, this sort of co-care payment or the establishment of the primary care commission, how is the budget is being detailedly told to the public, okay. But I think it's really important. And the second thing is that how to control the medical inflation, as mentioned by Professor Yuen. In the hospital, we are not going to control inflation, but we have to control our expenditure, how to control the money being used. And the third point I want to really speak out is that it's mentioned that everybody has about 50% of the admission can be managed in the ambulatory care. So I think it's talking about those cases in attending OPD, but we are talking about the money from the whole source. 18% of the money spending for primary care or spend the public health expenditure. But I think this counts for also for the not just in OPD, for all in every aspect, including staff, the staff not in OPD. Staff can be, if you talk about, we put all the case from hospital, roll out to the ambulatory care, then we need another kind of management. We need to probably employ, actually, I would say, we use the same kind of human resource, but that's when we have to be there. Staff. Now, if you talk about ambulatory care, besides just medical attendance as a clinic, you may have to consider about those of minor surgery, outpatient surgery, that will not require admission, but can be put in a day case, very much. But this also have to take care of, because we have to care about how is the theater running, how about your infection control, all this sort of thing. You put it out from hospital out to the ambulatory center. The sort of expenditure will still be necessary, but could be less because you cut down one shift of personnel, I mean the night shift. So I think maybe I'm not a statistician. Maybe professor can understand how money can be saved from that 50% those case put from hospital admission to the ambulatory care. This is the third point I really want to maybe somebody can entertain us. We are talking about the same of money from the government, I mean the public sector. But in the private sector, as I mentioned, I have a simplified picture for you, that's all. That's my point I want to raise up.
Thank you. Thank you, Dr. Wei.
Okay, I'm not really have a closing remark, but we really want to say something, Ben and I want to say something as a kind of acknowledgement. First of all, we would like to thank all the participants, particularly the three keynote speakers, Dr. Lam, Professor Kidd, and Professor Eleanor, and also all the speakers of these 2 days, and respondents and discussants as well of the 4 panels, and also all the participants online. In fact, we have altogether 489 participants in these two days, which is really quite good. That means we are quite impactful. But besides those like people on the stage, actually we have a lot of support. We want to say thanks to them. The first important one is the sponsor. In fact, the conference is sponsored by CUHK Strategic Events and External Projects Office as a kind of 60th anniversary of the university. That's why we have the budget to organize it. And in this conference, we actually, besides the Hong Kong Institute of Asia-Pacific Studies, we actually co-organize with different parties. And we want to say thanks to every organization, including the Center Aging and Healthcare Management Research at PolyU, and Hong Kong College of Community Health Practitioners, and also the Policy Research Unit at HKIAPS. And in particular, we are also really thankful to the government, particularly the Secretary for Health's office, and they do come, and different departments come and speak for different voices, and in fact they are so kind. Like in fact we had a emergency plan, and the emergency plan was about the typhoon, but they said they have a commitment. If they could not come yesterday, they could also come today. So they really have the commitment to do it. So really thankful for that, and they really want to. This is more like open communication, open approach. And besides, there are a lot of workers. You see a lot of workers and students helping. There are students from CUHK and also from PolyU, the CPC, and there are also colleagues as well. And besides us, besides Victor, Ben, and I, there are also those people who communicate with all you, like Tiffany. Tiffany, where's Tiffany? Tiffany, and Tommy, where's the Tommy? Tommy is over there, and also Oscar, John, and Oscar as well. Oh yeah. They are the person who work days and night for this program. I'm really thankful to them. Otherwise, we would not have this kind of arrangement, like so well organized. Thank you again very much. Do you have anything to say?
Again, we thank everybody for supporting and joining the forum in the last day and a half. We would like to see more of this kind of activity, either at the university or outside, and we also like to call on organizations, other institutions to join together, because the more we come together, the more opinion we can voice out, and I'm sure the government is listening, and hopefully they will take action. Thank you. Thank you again.